Good afternoon and welcome, everybody. We're back in boat ashore, as you can see. We haven't got face masks on. We're here. The day might not be sunny, but it's warm in our hearts because we're in the 5th day of stage 3 of where we were. And Dr. Brink will have some comments, some statements to make about vaccinations and all other matters, but also where we are with outbreak 2. Because thankfully, we've had 27 days, so nearly 4 weeks without any new cases of COVID. Isn't that fantastic? But you've never got this horrible thing beaten. And so we're still asking people to be vigilant, although the island restrictions have been lifted. But if you go somewhere, for example, like the hospital, and they quite properly, because people in hospital are sick, are asking you to wear face masks, you have to wear them. Don't give any of the staff grief. Please just wear face masks. Still maintain sensible discipline because we've got to be ever vigilant. But live your lives. Get on with your lives and enjoy them. Sadly, it's a year since we first locked down. I've said something about that in the States yesterday. I'm not going to repeat what I said. But I thank everybody in the bailiwick, all the sensible people in the bailiwick for their efforts so that we can continue to enjoy the freedoms that we're enjoying that very few places elsewhere in the world are enjoying at the moment. Even our good friends just across the sea, whichever direction you go, they're not enjoying the same freedoms as we are. But we can only do them if we continue to be sensible. And we will react positively and quickly, as we did last time if we have to. But let's hope we don't have to. Let's hope that everything is moving in the right direction. Now, what we're going to do, and I think that both my predecessor and I have established the fact that if there are things to tell the media, the people, they'll be told instantly. Good or bad news will be told instantly. But at the moment, it's steady as you go, business as usual. So we're not intending to have another briefing for a fortnight. 2 weeks today will be the next briefing, unless there is something that we think that we need to bring to people's attention, and then there'll be a briefing arranged at short notice. But otherwise, this will be it for a couple of weeks, so people will be able to enjoy Easter next week without hearing from me. There's always a pleasure of hearing from Dr. Brink, of course, but you won't have to hear from me or any of my political colleagues. Now, the next timetable will probably be towards the end of April, with the then traffic light system for various countries, districts, regions about relaxing restrictions on the border so that people can travel into the bailiwick. Because if you recall, we did relax from the 22nd, the fact that you can now travel into the bailiwick without having to be an essential worker. You can travel in, but of course you're subject to, as they will be for the next several weeks, the strict isolation procedures. We hope to be able to ease that over the next 5 weeks or so by the end of April. But other than that, and other than to say we want everybody to be vigilant, we want everybody to enjoy their lives going forward, you've heard enough from me, Dr. Brink.
So, thank you very much. And it is a year since we went into our first lockdown, just over a year, and it's been a year of incredible highs and lows. And again, I'd like to acknowledge the incredible support that we've had from the community and indeed from all of you over this period of time. Now, the good news that I have for today is we now have no active cases in the bailiwick. So we're down to 0 active cases. We do still have one person in hospital who was admitted because of COVID, but no longer has an active infection. So from a point of view of active infection, we have no known active cases in the bailiwick. So a good day for us, but of course we do hope the person has a speedy recovery. What I thought I'd do today is try and show you what's happened over the last wave in a different way to normally just presenting you the numbers. So as you're all aware, we've had 511 people become infected with the virus that causes COVID-19 in wave 2. And what you see from the graph in the top maroon line, you see a plateauing off of the number of cases. So you can see the cases plateauing. What you also see, thankfully, is the blue line going up, and you see the number of cases recovering, which again is extremely extremely encouraging, and the green line showing the number of active cases declining. And of course, we did have one death in the second wave. So we're in an extremely good position. We now are day 27 with no new cases, and we can now officially say that the second wave is now over. So encouraging for us as we move forward. So I'm going to present some cumulative results and some information that I think might be interesting for viewers. The first is, since we started testing on the 9th of March 2020, we've done just under 84,000 tests for the virus that causes COVID-19. And of that, we've had a total of 821 positives. So that's the 252 positives that we had in the first wave, the 511 positives we had in the second wave, and the 50-odd cases that we had positive in the interwave period. So that's a total number of positive cases. As I mentioned before, what has been encouraging is that we've had the lowest mortality in the British Isles, and that's something that I think is a positive thing to reflect on. So if we then move forward and look at some of the new initiatives we're bringing in. Now, I spoke to you about our surveillance programs and how we're using our greatly enhanced surveillance capacity. So just to remind you, at the start of going into the first wave, we were able to get 35 tests done per day, waiting about 4 to 5 days for those test results. So the swab to test result time at the start of the first wave was in the region of 4 days. Fast forward to the end of the second wave, our testing capacity is now an on-island testing capacity. We don't have to send samples off island. We can do between 1,500 and 2,000 tests a day, and our swab to test time is under 24 hours, usually between 8 and 12 hours. So we are in a fundamentally different position, and we've used that enhanced testing capacity to help us during the second wave. But we're always looking forward, and we always want to do more. So as we move and vaccinate our population, we're also looking at enhancing our surveillance program. And what we'll be rolling out from next week onward is lateral flow testing. Now, lateral flow testing has improved dramatically over the last year, and this will now form part of our surveillance program as we vaccinate our population. So it's to help us in this interim period of time until our population is vaccinated. And what it'll help us do is detect asymptomatic infections with the virus that causes COVID-19. Now, lateral flow is not suitable for detecting symptomatic people. We want those people to have a test, a PCR-based test. So anyone who's symptomatic needs to be tested with a PCR-based test. It's also not suitable for testing people who have been vaccinated. The reason being is that people who are vaccinated have lower viral levels, and so you'd want to use a more sensitive test. So we're targeting on very specific populations. And again, this is not a risk elimination, it's a risk reduction. We're looking at reducing the risk to the overall population by bringing that in. It's a self-taken sample, and people will do it twice a week. Now, the self-taken sample is useful. The reason being is that it means that people don't have to go down to the East Arm or indeed up to the PEH and drive through and get tested there, so they can test themselves in the privacy of their own home. Overall sensitivity, as I said, it's less sensitive than PCR, but you're looking at a sensitivity of just under 77%. False positive rates are extremely rare. So if anything, you're going to just have a reduction in sensitivity. And as I've said before, it's not suitable for people who have been vaccinated because it's less sensitive than a PCR-based assay. So all of those things means that we'll be rolling that out. We look at specific groups of individuals. We're using it in bailiwick law enforcement. We'll be using it in our teachers as well, education staff in the broader sense. So again, this is not going to eliminate a risk, but it provides us another useful tool in our battle against COVID-19. And what I also wanted to do today is just talk about our vaccination statistics. And if you recall, we have that balance between the non-pharmaceutical interventions, so the border controls, the social distancing and so on, and the increasing vaccination of our population. And if you look at the number of the doses that we've given per 100, and I say we always express that because it gives an international comparator, that's just under 48 per 100 population. And we've delivered now over 31,000 doses of vaccine. So really, we're moving in the right direction, and we're pleased with the progress of the vaccination program. But of course, we want to progress as quickly as we can. So moving on from vaccination, I was speaking to someone on the phone. They said to me, how do you check your information? And I don't think I've shown this information to you before, and that is how we continually sense checking what we do. So we test symptomatic people. So we have our surveillance program, look at symptomatic people. We're in constant contact with our hospital emergency department, primary care, but we also have our helpline calls. So our helplines are divided into our clinical and non-clinical helpline. And what you see in the blue line there is the spike of calls that we had to our clinical helpline starting just before the 22nd of January. So you can see those increase in numbers of calls coming to our clinical helpline, and you can see how it peaks at round about the 28th, 29th of January, and that was when we were seeing our most number of cases per day. And what you see now is those number of calls have come down significantly. So that's one of the things that we do when we say, well, we've had no new cases. How can I be sure that we've had no new cases? Well, clearly you can't be completely sure that there isn't an undiagnosed case, but we're tracking the whole time onto our helpline calls, onto our emergency department admissions, onto the GP data that we get on a daily basis. So we continually sense checking to see that our information is correct and there's nothing that we're missing. So one of the things that the Director General of the United Nations spoke about was the new dawn and how we move towards a post-pandemic period. And I think there are a lot of lessons that we've learned during the pandemic, and we need to keep carrying these lessons forward. And Deputy Fairbrash has spoken about some of those, but again, staying at home if you're unwell, report your symptoms to your GP or phone the clinical helpline. If someone comes forward and tests positive, they're not ruining anything for us. They're helping their community because it enables us to then control that infection, contact trace around that. But things that I'd like to see now integrated into our daily habits. So when you go into a supermarket, go into a shop, there's sanitizer, hand sanitize before you come in. That good hand hygiene. So those good habits, because we know that's really important in preventing infections. So again, your respiratory hygiene, your catch a bin at Kellet, sneezing into your elbow, really important as well. Face coverings. Now, Deputy Fairbrash mentioned face coverings in the hospital, and what we've said is that face coverings should still be used under certain circumstances. So think of the World Health Organization principles of the close to people, closed spaces with no ventilation, low roofs and so on, and crowded. And think of those. And when you think of those, if you think you're in a poorly ventilated situation with lots of crowds and so on, consider whether a face mask would be appropriate under those circumstances. So really do think about that. And then social distancing. And I was really impressed. I was queuing in a shop yesterday afternoon on my way home from work, and there was a queue and everyone had automatically spaced out, and I think retaining those good habits of spacing out is going to be so important as we move towards our new dawn. Now, before I go on to the last slide, I wanted to give a special shout out to the students of Lemuria. I came in yesterday to a set of the most wonderful letters from the students of Lemuria telling me all sorts of things about what they did in lockdown, learning to skate in their garden, so spending more time with their family, going on a newspaper round, doing those sort of things. And it was really interesting to hear, and I really would like to thank them and indeed their teachers for taking the time to send me those letters. There are about 30 or 40 letters, and it was so lovely sitting and reading them. I read them last night, and I have to say, you really made my evening, so thank you. The final thing that has been filling my inbox is, of course, Easter. And there's been a lot of concern about the Easter Bunny and critical worker status. And so very pleased to note that the Easter Bunny again will be given critical worker status. They've been well briefed about poor hygiene, safe delivery, social distancing, and so on. So to the children of the bailiwick, the Easter Bunny, has been granted critical worker status and will be visiting us this year. So that's good news for us. So thank you, Deputy Fairwash.
Thank you very much, Dr. Brink. Your comments about the children from Lemuria are great, and you talk about some of them going on paper rounds. Well, I used to be a paper boy all those years ago. It's taken me all the way back, but we've got to look forward and not back. So thank you very much for that. Right, ladies and gentlemen of the media, can I have your questions, please? And because we're doing it live, as it were, rather than by teams, can you say who you are so that it's identified? Yes.
Hello, it's Juliet from the Guernsey Press. I was just trying to find out how many lateral flow tests you've ordered and how long you envisage us needing to use them for.
Yep, so we've got about 80,000 lateral flow tests, and we'd envisage using them until our population has had their first dose of vaccine. So that is phase 2 of the vaccination programme. That's all eligible people over the age of 18 years. So, and what we'll then do is we'll phase out the surveillance and as the vaccination programme phases in. So I have all these complicated diagrams sitting around my office. My office has got all these things on the wall. But as our population becomes increasingly protected, and indeed, as I said, the lateral flows aren't appropriate for people that have been vaccinated because you'll lose some sensitivity, so they're less sensitive than a PCR-based assay. So I would envisage, to answer your question directly, using it till round about end of May time.
Thank you. Yes, Ewan.
Ewan Duncan, BBC Guernsey. Just sticking on lateral flow testing. Is it something that we'll continue to do when we open the borders more fully for those who might not have been vaccinated so that we can test them once we don't have to do a strict coronavirus test on arrival?
We're looking at a number of things post the full opening of the borders, a number of mitigations that we can consider, and I think it'd be premature for me to say anything about this now, but it is something that we're discussing in detail, and in fact we're writing a paper on it with an options appraisal of how to retain a degree of security as our population is increasingly or even totally vaccinated. Of course, after phase 2 of the vaccination programme, we'll then consider phase 3 because there are studies on vaccination in children now happening. So we'll always look forward as to what else we can do.
And why there was a slight hiccup, it's my fault, is because in relation to what will happen when the borders gradually open, they're opening in phases, is that we're looking at all kinds of what we need to do, what's the best to do to move people but to be safe. So there are all kinds of considerations, and that will be kept under review as more medical evidence, more scientific evidence, and hopefully more people are vaccinated. Next question, please. Kate.
Kate Prout, ITV Channel. I know in the UK there have been some issues with procuring all the vaccines that they're expecting. Has that had any impact on the bailiwick?
Dr. Green.
So we receive a proportionate amount, and that's 0.1% of the total UK allocation. So we are dependent on them for their supply chain. But we're also in a favourable position. So, for example, if an area isn't able to use their vaccine, we're able to administer it. So we'll take as much vaccine as we can get, but we will always be dependent on that UK supply chain, and there's a degree of unknown there.
Thank you. Yes, Matthew.
Thank you. Matthew Leach, Bailiwick Express. This is a topic I've asked about before, and I thought I'd like to return to it again. From emails we've received and from personal conversations I've had now, it sounds like the vaccination algorithm continues to invite young people without underlying health conditions and missing people who should have been invited. Is this a bigger problem than simple algorithm outliers? And do we have the stats on people who've been invited for a vaccine when they shouldn't have?
Yeah, I think Dr. Britt will come to that, but we looked at whether, because you've raised that point and others have before, and it's a very good point to raise, and we've had calls, well, we know so-and-so, he's 35 and he's had a vaccination and we're 62 and we haven't. And of course that does merit being looked into, absolutely. Sometimes if we were to alter it and just be purist, it would take longer than continue to vaccinate people, because the idea is to get to vaccinate people. But I think the problem has largely been eradicated, and that generally the people who are vaccinated have good reason to be vaccinated, even though it might not be readily apparent. Do you want to add anything to that?
Yeah, I would say that if anyone feels that they are in a priority group and they haven't been called, to please contact the vaccination helpline,
absolutely,
because we can then assess the situation and see whether they should have been included. Some of the people that I've spoken to who thought they should have been included, in fact, didn't fulfil the criteria. So it's I think as ever a combination. But if people, I would encourage people, if they feel that they should have been included and they haven't had an invitation, please contact us.
Exactly, because we don't want people to be agonised or angst because they think they've been missed. Next question, anybody? Yes, Juliet.
Yes, Juliet from the press again. Obviously, currently we're using the Pfizer and the AstraZeneca vaccines. Checking with the UK, it looks like they're expecting to have some of the Moderna vaccine coming to them very soon. Do we have any dates on when we're likely to see that coming into us as well?
So we're expecting that at the end of April, and we've written what's called our PGD, our patient group direction for it. It's gone through our pharmaceutical committee, and so we've done all the background preparation as well. It's just waiting for final sign-off from our Committee for Health and Social Care, but we're expecting the vaccine only at the end of April, but we've got all the policies, procedures and mechanisms in place to deliver it as soon as it's arrived.
Next question, please. Yes, sir.
Touching on something that Dr. Brink said, saying the second wave is now over, which is fantastic, obviously, for everyone. Yep. Does now the focus move from the bailiwick thinking about health, and we know how fantastic the vaccination rate is, and now we must focus on the economy and getting things back to a more normal level on the basis that we feel confident in what we've done on the health side of things?
Yep, exactly. Albeit we must always have focus on the health things because that can change. And I'm just doing the arithmetic. It's 9 weeks today, or 9 weeks in about 6 or 7 hours when I got a phone call. Dr. Brink had a few hours before that there was a problem. So we don't want to go back to that. We want to cast aside those 9 weeks. But the economy's got to be a focus. I mean, people have got to earn livings. People have got to, they've got to be able to travel. You know, they want to go and see their families. They want to go on holiday and all the kind of things that normal people want to do normally. But the economy is a real focus.
And does that mean that we now need to consider opening the borders on the 1st of July, come what may, whatever is sort of happening around us, or do we still want a more cautious approach to thinking about our neighbouring jurisdictions?
It can't be come what may because we don't know what may come. I mean, look at France, for example, at the moment. They're in a pretty dreadful state, and they're only a few miles away from us. But we hope that by the 1st of July, which is just over 3 months away now, that we'll have sufficient procedures in place and sufficient considerations that we'll be able to move to it. That's the intent. There's no change from what I said a few weeks ago, but nobody can give a guarantee. I mean, if there's some real variant comes along, or we have a real problem with neighbouring jurisdictions, then that's what we would do. And it may be that it'll be restricted, because it may be that some countries will still be in a very difficult position. Do you want to add to that, Dr.
Yeah. I think that's absolutely so. We need to see where we are at that time. We need to see what's happening in the neighbouring jurisdictions. And we analyse that on a weekly basis. So we look at the prevalence in countries on a weekly basis. We've analysed it down to jurisdictions in France and the UK as well. We also look at other public health parameters such as hospital admissions, mortality, testing rates, and so on. So we're looking at it. This is not something that we'll just think about in June. We're working and looking at what's evolving. We've also got access to information on emerging variants and looking at the impact of emerging variants, particularly the vaccine efficacy with emerging variants. So I think all of that we'll take into consideration. But as our population becomes increasingly vaccinated, our situation improves dramatically.
Matthew, then you, Juliet. Matthew.
Thank you very much. Do we know yet how long a vaccination covers us for? Should we be expecting boosters next year? And do we know what kind of infrastructure we'll need to do this?
Yeah, I think we'd all like to know that answer to that question. The answer is we don't even know how long the immunity to a natural COVID-19 infection lasts, because the virus just hasn't been around that long enough for us to look at it year on year. So with regard to the immunity, we know certainly up to 6 months there'll be good immunity, both from a natural infection and from a infection and from vaccine-induced immunity. Beyond that, the studies still need to be done on that. With regard to will we require an annual boosting, that will depend on the degree of variation that occurs. So there are two things. One is the duration of immunity, and the second is the emergence of vaccine-resistant variants, which might require some tweaking of the vaccine. Those are unanswered questions at the moment. And I think planning for the infrastructure to deliver that will it'll depend on what we're trying to deliver. So I'm not trying to evade your question, but actually we need to look at what happens. We need to look at the duration of immunity. We need to look at the impact of vaccine-resistant variants. And interesting, the data is emerging all the time. So just this week, a paper came out which showed although the neutralizing antibodies might not be effective against some of the variants, that you might have a cell-mediated immunity, which is another part of your immune system that is effective and that might be protective. So that data is emerging all the time, and we watch it and we'll integrate it into our policy making.
Juliet.
I've just got a question in relation to the bailiwick blueprint. Obviously, we've had some questions about the 1st of July, but looking at the 30th of April, when we're hopefully going to have the traffic light system, from my reading of that, if you have an area where it's got less than 30 cases per 100,000 in the previous 7 days, it's pretty much a test, negative and release programme with no isolation. Looking at the areas around us, I think specifically Jersey is obviously well below that. The southwest of England have also been consistently just below that, and the south east of England is only just above that. Are you feeling optimistic that in a month's time, I know it's hard to predict, do you feel hopeful that we might be able to have be able to travel to some of these regions almost freely when we get to the 30th of April?
We are hopeful that exactly the points you've raised. You know, you've read this part of England's better than that one, this jurisdiction is better than that. That's exactly what the traffic light system is. And it'll operate, there'll be different rules for different parts of the traffic lights.
Yeah, exactly. And yes, we are optimistic. It's looking good, but we don't know what's going to happen. I mean, Europe's experiencing a third wave in many places, so we don't know how that's going to impact on the UK. And if this pandemic has taught me anything, it's you need to just look at the evidence as it emerges. But overall, I am hopeful because I would like to see people being able to travel more freely, to see family, friends, and so on. So I think that'll be good. And you're right, if you're under 30 per 100,000, if your prevalence is under that, it's a test on arrival, isolation until you get that negative result, and another test on day 7. So actually a lot of people would find that probably quite acceptable.
Okay. Ewan?
And just touching on what Juliet said there about the regions in the UK which are obviously doing better, is it something that the government will look to work with our transport providers and especially Aurigny to say, look, we need to be going to this airport because it's in this fantastic area, and it'll be a boost to Guernsey and their economy?
The answer to that is yes. I mean, clearly, already have got to be able to gear up, and I think they will. If the chief executive said relatively recently that they needed a period to gear up, but that's general gearing up. So the answer will be yes. I mean, let's just say there are lots of people in the London area. There might be more prevalence to go to Gatwick, say, or something like that, or Manchester, or wherever it may be. So we would expect, especially a state-owned airline, to be fleet of foot and speedy in the air, within the bounds of reason.
But there's going to be a genuine push from government to say, we want you to go here.
Of course, absolutely, because we want people safely to be able to travel. We want people to be able to come into and out of the bailiwick safely. Fortress Guernsey is a phrase that's been used, I think, inappropriately. We want Guernsey to be as open as it safely can be. Anybody else with a question? Yes, Juliet.
I was interested, obviously, in the vaccine programme, obviously, health and social care staff were some of the earliest to be vaccinated. I think they've all had their first and second doses if they wish to have it. I was just interested to try and find out what the take-up has been like amongst health and social care staff. And is there ever any thoughts possibly making it mandatory? Or if not, and people choose not to have the vaccine, will that affect what work they can do where in the health and social care sector?
So I think that's a very difficult question to answer. I think you all know that I'm not a fan of mandatory vaccination, in that I would prefer to engage with people and have discussions. And to date, we've managed to have a very high vaccine uptake against a number of vaccinations. So, for example, our MMR uptake is above 95%, so way above the World Health Organization target. So we managed to get good vaccine uptake by engagement. Should we have really poor vaccine uptake for some reason, it would be something we'd have to have a discussion on. But having said that, I would look at engaging with people. I don't have the exact figures, but our feeling is that we've had a good uptake. We've had few people refuse the vaccination, and I think active engagement in discussing, and often people just want to discuss the vaccination, so they might say, well, I'm not sure, and being available and open to discuss the vaccination I think is really important. And I think you'll get far more engagement if you work with people than if you impose things on people. So I think we'd look to working with people and not making it mandatory unless there was something absolutely compelling that changed.
Anybody else with a question? Yes, sir.
I was going to ask about people in self-isolation. You might not know the numbers, but is it quite a relatively low number now of people in self-isolation?
None.
She knows the answer.
No people in self-isolation. So as a result of COVID, obviously incoming travellers is a different story, but as a result of COVID either being a case or a contact, we're down to 0. So just remind you, when we were at the peak of the second wave, we had thousands, but we're down to no people in self-isolation as a result of being a case or a contact of a case of COVID, but we will, of course, have people who've travelled in that are in self-isolation.
Anybody, any other questions? Yes, Juliet.
I know you've previously asked people who are symptomatic to obviously come forward, and I imagine during the height of the second wave, anyone who had a cough was obviously coming to you. But are you still finding that people, when they are getting symptoms, sort of COVID-like symptoms, are still coming forward to get tested, or would you want to encourage more people?
We'd like to encourage anyone that has any of the symptoms to come forward and be tested. That's so important, Juliet, and then even if they have mild symptoms. Now, our testing policy is different from other jurisdictions because we've got a very broad testing policy. We'd like to throw the net wide and detect anyone who could possibly be positive. We'd rather have more negative results and detect that single positive. I think that's really important. And the other thing that I'd like to particularly stress, that if you do come forward and you test positive, you're not spoiling the run. People mustn't feel like that. You're actually doing your community a favour, because it enables us to manage that infection, contact trace, and so on. So anyone who has any symptoms, we'd like to be tested. What we think is there is an overall a reduction in the number of people with respiratory symptoms, and that's reflected not only in our emergency department attendances, but also what primary care are seeing. So primary care send us data on the number of people presenting to them on a daily basis, and it also is our clinical helpline. So we're always checking multiple data sources and trying to sense check and make sure the data is correct.
Anybody else with a question? No. Well, I wish everybody a happy Easter. It'll be the other side of then when we next see you. We're very grateful. As I say, I think I'd like to finish on a point that Dr. Brink has made continuously. We are in the position we are because of the good sense of the people of the bailiwick. So thank you very much. Continue to be prudent, and continue to enjoy where we are now. Thank you very much indeed.